Good morning, everyone. I want to start just by welcoming all of you to this webinar on data sharing and the law. I'm Laura Gottlieb, the Director of the Social Interventions Research and Evaluation Network, better known as SIREN, an initiative based at the University of California, San Francisco. The world is in the midst of a global crisis with many local differences. I'm glad that so many of you were able to join us and very much hope that the discussion today will help you as you continue caring for your communities during these strange times. So I've been assigned the truly riveting task of attending to some housekeeping items before we start the presentation. So first, this session is being recorded, as some of you have already asked in the chat. And the recording will be available next week on the SIREN website. Second, all participants are muted. I'm hoping, though, that you will both communicate with one another and pose questions to the presenters using the chat box. We'll be moderating a discussion after the presentation, and we will share the questions as many of the questions as we can get through that are posted in the chat box. I do want to apologize in advance for not being able to get to everyone's questions. Be reassured that our speakers have shared their contact information and are happy for you to communicate with them post-webinar if your questions are not answered over the course of today's session. I also want to extend SIREN and Manatt's gratitude to the Robert Wood Johnson Foundation. The foundation hosted the convening where their grantees helped spark the idea for this project. They helped to support the National Academy of Medicine's Committee on Integrating Social Care into Healthcare Delivery to Improve the Nation's Health, where Cindy Mann and I were able to dive deeply into conversations about today's presentation topic. And they supported the development of this report more specifically. We really appreciate the Foundation's commitment to helping us all figure out this complicated stuff. So with all that said, it's time to finally get down to business. In the course of our work at SIREN, we have some really fabulous opportunities to work with many brilliant partners, and I'm delighted to say that that includes both Cindy Mann and Alan Dworkowitz, today's speakers from Manatt Health. Cindy and Alex will share findings from a report they finished earlier this month and that is available on the SIREN website for those who haven't already reviewed it. As I turn this over to Cindy and Alex, though, it would be a mistake for me not to share with this group the tremendous expertise they have on this topic. Cindy has more than 30 years of experience in federal and state health policy and expertise in Medicaid, the Children's Health Insurance Program, and federal and state health reform. Prior to joining Manatt, Cindy was Deputy Administrator at CMS and Director of the Center for Medicaid and CHIP Services during the implementation of the Affordable Care Act. Her colleague Alex Dworkowitz is a partner in the Health Regulatory and Transactional Group at Manatt. He advises clients on health privacy issues specifically related to HIPAA and other privacy laws impacting the exchange of data among providers and social service organizations. So I will turn it over now to Cindy to share more about the rationale for this report.
Great. Thank you so much, Laura. So first I want to say thank you to SIREN and to the Robert Wood Johnson Foundations for their support of this work and also really for their ongoing efforts to deepen the evidence-based resources available to all of us, working to better integrate effective social needs interventions into the healthcare delivery system. Today we're going to talk about removing barriers to successful integration, and specifically we're focusing on the barriers that can prevent the exchange of information between the healthcare sectors and entities, different kinds of entities that can help deliver or facilitate the delivery of whole person care. Oh, I was a little too excited about that one. Here's our agenda for today. I'm going to just briefly review the background on this project. And then I'll turn it over to my colleague, Alex, who will go through really what the meat is of this presentation and the report, which is our use case analysis and then pulling together some concluding thoughts. And then, as Laura said, we'll have some time for questions and answers. So let me skip to the project background. I'll tell you a little about how we approach this. Of course, we are all here because increasingly there is a recognition that patient care involves linking patients, linking people to social services that are just so key to their ability to thrive, to be as healthy as possible. And I think it's clear to everybody, it's certainly been clear to us in our work at Manatt, that the importance and the value of this kind of engagement has been really underscored by this pandemic. Hunger, isolation, stress, just to name a few of the factors, have markedly increased and, of course, had significant impacts on people's health and well-being. But, of course, coordinating across healthcare providers and community-based organizations and other entities requires data sharing. We need to pass information back and forth to each other. But privacy laws, which, of course, have an important role to play in terms of protecting personal information and personal data, they weren't written with the idea of an integrated delivery system in mind, with a mechanism, with a system which pulled together some of the social services providers, school health clinics, food stamp program. Privacy laws just didn't contemplate that kind of integration. So it's not even just that they sided more on privacy than on disclosure. It's really that we are taking some laws that in a square putting them in a square peg in a round hole. So our goal in this analysis, and you see some of the key privacy laws that Alex is going to be referencing as he goes through the presentation, and he'll go through those in a little bit more detail later. But our goal in this analysis is not so much to convey, here's the answer for exactly this kind of situation, but really to identify how privacy can be appropriately protected within the context of integrated delivery model. So let me just tell you a little bit about how we went about and did this work. First of all, I want to say that it builds on and complements other work in this area, and some of those resources, really valuable resources, we wanted to point you to. They're reviewed a bit in our paper, but also in the last slide of the deck. So other resources to look at. For our analysis, what we did in consultation with many of you who are working on these issues day to day, we developed 4 hypothetical situations, which we refer to as use cases. We think they reflect some real-life circumstances where a healthcare provider is seeking to share information with another sector. We examined for each of those use cases, and we're going to go through them briefly with you on this in the webinar. We examined those use cases in the context of restrictions on data sharing that may be imposed by federal law, and also because state law is very relevant in this area. What we did is we examined these use cases also with respect to the law, key laws anyway, from California, Louisiana, and New York, to just give a smattering of states with different approaches to privacy regulation. I want to note that while the focus was on healthcare sector sharing with other entities, we looked at the bidirectional while we're in the neighborhood. So if the healthcare sector can share with the jail, can the jail share back with the healthcare sector? And we also looked at the implications for using electronic platforms, which are becoming more and more common, to facilitate this data sharing. I'll just note that our analysis is intended to provide insight. It's intended to show that pathways are mostly possible, but it's not legal advice. And of course, the disclaimer that for any real-life situation as opposed to a hypothetical situation, and for a real-life state and jurisdiction, you'll want to consult legal counsel. So with that, we're going to start with going through key findings and then each of the use cases, and I'll turn it over to my colleague, Alex.
Thank you very much, Cindy, and thank you all for joining us today. So in terms of the big key takeaway from today's discussion is simply that when you talk about data sharing between the healthcare sector and other sectors, is that this is an activity that is often allowed, often can be done. There is no federal or state law that prohibits healthcare organizations from sharing data with the social service sector or the criminal justice sector. Likewise, there's no law that prohibits social service organizations from sharing with other sectors, and the same goes with the criminal justice sector. So the key message, I guess, here is one of hope, is that, there are ways to do this, to structure data sharing in compliance to the law, even when data is being shared with partners who you traditionally maybe haven't shared with in the past. Now, that being said, there are really important safeguards in how you do this, and typically the most important one is the concept of getting the consent of the individual or individuals whose data is being shared. As you can see when we go through the use cases, many of the times consent is required. Some cases is not, but that's important item to keep in mind. Because consent typically often is required, we need to think about how difficult it is to actually ask someone to sign a consent form, or in some cases actually verbally provide consent. In some of the scenarios we talk about today, doing so is fairly easy. Others, it's much more difficult. And also because consent is really important, we have to think about what must be included in the consent form. This is one area where things can get pretty complicated because there are a lot of different laws at issue. Some of them have specific rules about what needs to be in a consent form, and those rules can often be somewhat contradictory or hard to accommodate in a short form that's supposed to explain to someone how their information is to be shared in a plain language type of way so someone can actually understand what's happening. And finally, another kind of key takeaway that we'll get into a little bit more is that oftentimes the legal requirements can be vague or ambiguous, and that obtaining clarification from the relevant authorities can be really important. So we took a look at a bunch of privacy laws. As Cindy mentioned earlier, this is not intended to be legal advice, so we certainly didn't look at everything. So this is just examples of how things work. The main categories are health privacy laws, benefit laws, criminal record laws, and the homeless management information system, which is a good source of information on housing history and records for those who have been homeless. In terms of health privacy laws, the big one is the Health Insurance Portability and Accountability Act, privacy and security rules, otherwise known as HIPAA. That's the main federal law that regulates health information sharing. Another important federal law is 42 CFR Part 2. That's the Federal Substance Use Disorder Confidentiality Regulation. We also include the Family Educational Rights and Privacy Act, known as FERPA here, and that may seem surprising because that's primarily an educational privacy law, but the reason why it applies is that to the extent schools have health records, those are typically going to be subject to FERPA and not HIPAA, and the FERPA rules differ from those under HIPAA. And there's also many state laws that often apply to many different, very particular types of health information, such as mental health or HIV laws. The benefit laws, we're looking at Medicaid and supplemental nutrition assistance programs, SNAP. And finally, as I mentioned before, there are also criminal records laws that we'll touch on. So with that, maybe we can dive into some of the use cases and see how some of these concepts actually play out. The first is an example of a clinician trying to connect one of the patients of the clinicians to housing. So the scenario we have in mind is that a clinician may be treating a patient who's homeless, who's an adult, and has a serious mental illness. And the clinician determines that this person could benefit from having housing. Maybe they don't have housing at all, or they have some transient housing, but regardless, there's someone else with expertise in finding housing who can help them. So the clinician refers the patient to that housing provider, and the housing provider seeks information to provide services to that individual. That one place they seek information is from the referring clinician. That could include regular health information, could include behavioral health information, such as substance use disorder information. The housing provider may seek information from other sources as well. For example, criminal history information. And in some cases, an individual's criminal record is relevant to what types of housing they're eligible for. And finally, the clinician wants information back. The clinician wants a closed-loop referral, wants to understand whether this individual actually was helped by the housing provider, whether they were placed with housing. So that's the scenario that we have in mind here. So what can happen under this scenario? So general thing at 30,000 feet, can data be disclosed in this scenario? Yes, but written consent will be required in some cases. And so in terms, when you think of the main information flow that's occurring here, it's going from the clinician to the housing provider, right? The clinician has his health information, the housing provider does not. And so can that data be shared? Here, there's a difference between states. Here state law is really important. California generally would require written consent. Louisiana typically would not. But there is an exception where providers are operated by the state health department. And in New York, written consent typically is not required either, but New York has sort of this consent concept of verbal or implied consent. So implied means, for example, if you're a clinician treating this individual, you say to that person, I'm going to refer you to this housing provider. I'm planning to share information with them about your past history. And if the person says, okay, doesn't object, that's viewed as sort of implicit consent to share, and you don't need something written. Written consent will be needed if any of this information is subject to 42 CFR Part 2, the substance use disorder confidentiality regulation. We don't really have time to get into all the details of how Part 2 works, but just know that just because the clinician has some information about an individual's substance use disorder history, that doesn't necessarily mean it's subject to Part 2. There's a whole different test. So just some of it may be subject to Part 2, some of it may not be. It's just something to keep in mind. In terms of the information flowing back to the clinician, the housing provider may confirm the receipt of services through a closed-loop referral. And if the housing provider needs other information, such as from HMIS regarding housing data or criminal records, there are ways to obtain that too. One, for HMIS, generally they're going to that housing provider will need to enroll in the particular HMIS system. In criminal records, there are some limitations, but it's important to keep in mind that oftentimes there are publicly available versions of criminal records. For example, my understanding is that almost all states have databases of sex offender records, and so if there is a restriction on housing for sex offenders, that's something the housing provider can find out. Many other states go a lot further than that and have some limited criminal records publicly available. The next scenario we're thinking about is the school health scenario, and that's one where you have a health clinic and a school health program who are jointly providing care for a student. So the school health program is based in the school itself. So here they're looking at data both ways. The school health program wants protected health information, which is health information under HIPAA, from healthcare providers in the community because it believes that information is valuable towards treating its students. And likewise, these community providers want information from the school health program. There may, other than healthcare information, there may be information that they seek regarding benefits, such as whether their students are enrolled in SNAP and Medicaid. As many of you know, for many schools, it's really important to connect their students with as much meals as possible, and sometimes there might be gaps in that data, and therefore the school may be seeking information from SNAP and Medicaid about income eligibility and whether these children may qualify for free or reduced price meals. So what can occur? Can these data exchanges generally happen? Yes, although written consent is always going to be required. Now, why is that? I mentioned FERPA before, and FERPA's standards are different at HIPAA. And generally, a school health program is going to need consent of a student's parent in order to disclose information to community providers. Information going the other way, however, is subject to HIPAA, so typically written consent will not be needed. So that means it's easier. It's sort of there's an imbalance here in this scenario, right? It's easier for data to flow into the school than for data to flow out of the school. That doesn't mean that consent is never needed for disclosing to the school. Again, I mentioned Part 2, which generally requires consent, and we also talked before about some of the laws in the states where written consent is required. And here, in terms of SNAP data and Medicaid data, it's the school district, not the school itself, that may obtain this data for purposes of enrolling its students in free or reduced price meal programs. Federal law certainly encourages school districts to obtain that data to connect these students with those benefits. So we'll move on to our third scenario here, which we're terming prisoner reentry. So this is about a scenario where an individual is incarcerated and is going to be released soon. And we're talking about a prison's health services unit, which may be separate from the prison itself. We're not talking about correctional officers. We're talking about clinicians, physicians, nurse practitioners, etc., who work in the prison itself and help provide medical services to individuals in the prison. So that health services unit wants to identify healthcare providers and community-based organizations that provided services to the individual prior to the time that individual was incarcerated. And the reason they want this data is because the health services unit wants to send alerts to those providers and CBOs to inform them that the individual is being released. And the purpose of those alerts is to try to connect that individual with services once that person is out of prison. The thought is that if there's a primary care physician who treated this person, a couple of years ago, that physician should be reconnected with the individual. And also, the health services unit seeks to know whether the individual's Medicaid was suspended due to the incarceration status. Again, here the purpose is to help connect the individual services post-release so that the individual can be re-enrolled in Medicaid if that's appropriate. So, going to the overall conclusions. Is data disclosure allowed? Yes, written consent sometimes will be required. So when we're thinking about the disclosure between the providers and those providers in the community and the prison's health services unit, generally that can be done without written consent because these are both, think about HIPAA. HIPAA generally allows disclosures between different types of health providers for purposes of treatment or care management. And that's what we're talking about here. This is really a treatment care management use case. However, there are limitations on when you may need consent, and these sort of mirror what we've talked about in some of the other scenarios. The first is under 42 CFR Part 2. Again, if this information is subject to Part 2, written consent typically would be required. And I mentioned the Louisiana requirement about a provider being owned or operated by the Louisiana Department of Health. And in New York, there's this concept of informed, the reason the individual needs to be informed is there needs to be implicit consent at the very least, or verbal consent. So in terms of the alerts that we're talking about, the prison's health services unit generally may say and send alerts to providers in the community of the pending release without written consent. Again, this is really a treatment care management disclosure consistent with HIPAA. there is a bit of a lack of clarity here as to whether that can be sent to CBOs as well. And when I say CBOs, I mean organizations that are not HIPAA covered entities, a housing provider, a food bank, etc. That is sort of an area of ambiguity in the law. In California, the way their health law is written, it's a little stricter than HIPAA in this regard, and so written consent would be required to send these alerts to community-based organizations. In terms of the Medicaid suspension status information, that's something that could be obtained if the health services unit sort of enters into a contractual agreement with the state Medicaid agency to help administer the Medicaid program. If that doesn't occur, then they're going to need written consent from the individual. So I'll turn to the last use case here, which is about food stamps. And here, this is from the perspective of a Medicaid managed care organization. The Medicaid managed care organization is trying to improve the level of health among its members, and they believe that some of its members are entitled to food stamps but aren't enrolled in the program. So they're trying to figure out ways to make that happen. And partially you could view that as something out of goodwill, but also there may be a motivation for that in terms of maybe the Medicaid MCO's quality scores, is that if they make sure that people have enough food to eat, their members, that they may have a positive impact on the MCO's quality scores. So how is the MCO going to do this? They need to understand who is enrolled in food stamps, and whether, and for those who aren't enrolled, whether they might qualify. So they're looking for, SNAP data on current enrollment and potentially Medicaid data as well to determine what's a person's income eligibility. And then once the MCO determines who's eligible but not enrolled, it reaches out to those individual members and tries to assist them in filing SNAP applications. So this is one scenario where sort of the conclusion is a little up in the air. And sort of the main question here is sort of about the rules regarding Medicaid data. So Medicaid data is subject to HIPAA, but it also has its own rules under federal Medicaid statutes and regulations. And the key requirement is that, generally speaking, data can only be shared if the data is shared for purposes that are directly related to the administration of Medicaid. So what does that mean? It's not clear, and here in particular, the goal of the data sharing is to help connect individuals to food stamps. Is that directly related to, is reducing food insecurity directly related to the administration of Medicaid? Maybe it's not. I don't know. But the point is that there's a lack of guidance on this issue. So from the MCO's perspective, from the state agency's perspective, it may be unclear of how they should proceed. There's also sort of a second ambiguity here, as I mentioned, because it not only does this need to comply with Medicaid privacy law, it needs to comply with HIPAA. And so there's a need to understand whether this qualifies as a population-based activity related to improving health under HIPAA. Now let's assume we do conclude that we need consent here, that we just think these rules are too ambiguous and there's a risk to the state, to the MCO, if they share this information without the members agreeing to it. Yes, you can ask for them consent, but here this is a scenario where asking for consent may be more difficult, right? Because here we're trying to determine potentially connecting thousands of people, tens of thousands of people with food stamps. So do you need to get consent from all those people? Yes, probably. And that's not easy if you think from this perspective as state Medicaid agency or an MCO. They don't generally have direct contact with their members. So they don't really have great opportunities to ask them to sign a consent form. In terms of obtaining data from the SNAP agency, here's a little more clarity. The SNAP regulations suggest that the SNAP agency may share data with the MCO if the parties enter into an agreement, and under that agreement, the MCO agrees to assist in the administration of SNAP and abides by certain SNAP rules, including security requirements. So, summarizing all this together, going back to our original key findings, you said the first kind of point was information typically can be shared, particularly if someone signs a consent form. In all four of these use cases, we came to the conclusion that information could be shared in at least some circumstances. And typically, if someone an individual signed a written consent form, knowingly agreed that to allowing their data to be shared, most of the information could flow. But going on to that second point is okay, you need to obtain consent. How hard is it to obtain someone's consent? So let's think about the prisoner reentry use case. That's one where obtaining consent is probably not that hard, right? You have an individual, that person is in prison. You can have a conversation with them, explain that you're trying to connect that person to services post-release, ask if they're willing to provide consent to share their information. That's sort of a doable circumstance. So there, maybe consent is not really a big barrier. But in turn, think about the school health and food stamps use cases. That's a little bit different, right? School health, when you're talking about, say, a 9-year-old, it's not the 9-year-old who's signing a form, who's providing consent. It's that person's parents or their guardians. And so the school may not be in direct contact with that person. It might be very hard to have a conversation with a parent and guardian and obtain a consent. So there, the process of going through and asking someone for consent can be a big issue, even if that parent was totally willing to grant consent. You need to find that parent and talk to them. Similarly, the food stamps case, as I mentioned before, here you could have tens of thousands of enrollees potentially who need to sign consent forms. That is not going to be easy to track down that many people and get them to sign forms. Keeping with the theme of consent, requirements about what needs to be included in consent forms can make things more difficult. So a good example is 42 CFR Part 2, the federal SUD confidentiality regulation. That regulation as currently written typically requires the form to name all potential recipients on the form. So there's a certain logic to that makes sense. If I were signing a form, ideally I would want to see the names of the providers or CBOs or whatnot who can receive my information. But if you think about how this works in practice, imagine there's an individual who has one primary care provider, and they sign a form and it has that name, that primary care provider as a recipient. And then a couple months later, they switch PCPs, and or they get a new specialist, or they have a new. That essentially means you have to sign a new form, and so that's not great. It's a logistical challenge, but also, from the patient's perspective, the individual's perspective, some their attitude may be, I want my information to be disclosed to my treating providers generally. I don't want to go back and redo this every time I see a new doctor. Along those lines of consent requirements, we didn't get into the details of Louisiana law, but in some cases, Louisiana also requires consent forms to name all potential recipients, and it also says a witness needs to sign the form. Okay, think about the times we are in, right? COVID. No one wants to bring extra people in the room, so now you need to have not only do you have to have the individual, their provider, meeting to have a signed form. You have to bring a third person in as a witness to sign the form. I mean, that can be pretty difficult. How clarification of legal requirements can promote data exchange. The food stamps case that we were talking about before. Can a Medicaid agency disclose data for purpose of enrollment in SNAP? Again, it's not clear whether that's permissible. And here's an area where guidance could be helpful. And again, another area. Does HIPAA permit a CBO to receive alerts on individuals impending release from prison? if those alerts come from a health services unit of that prison. You know, I think HIPAA seems pretty clear that if it's a covered entity under HIPAA, you know, a clinic, that's okay. But if it's a non-covered entity, that's a CBO, is that permitted? I'm not sure. There's an argument for it, but it's not crystal clear. And the role of state law, finally, you know, we think back to that first use case of connections to housing. There, whether the information can flow from the clinic to the housing provider, that was significantly impacted by state law. And so state law can become very important. But if you go to the food stamps case, that really was dictated by federal law. So just to wrap things up in terms of recommendations for putting this all together, you know, I'll go through these sort of one by one because I think they're all important. The first important step is to begin with a detailed model of how this information, how this data is going to flow. You know, the devil's in the details, particularly when it comes to privacy laws. And I think it's important to start with the way that the parties involved want the information to flow. You know, start charting out, we want this organization to share with this other organization, and then you can sort of look to see if that can be done. But it's important to kind of get into the details. Who's sharing information with whom, using what platform, for what purpose. And once you understand that, you can have a better sense of what laws apply and what they permit and what they don't permit. Second, develop a common understanding of applicable laws. You know, again, sometimes the law is very clear, but sometimes it isn't. You know, we're in this, you know, there are assumptions in this deck, there are assumptions in our report that about how law should be interpreted. You know, they may be correct in many cases, but they may not always be correct. And people have different visions of what law allows. Some people are more pro-data sharing and want to interpret law in that way. Others are a little more conservative and really want to view data as being withheld and protected unless there's a very strong, this is very clear that the law permits it. So when you talk about different parties in different sectors, they may have very different cultures about what can be shared. You know, a healthcare provider may feel differently about the sharing of certain information than a community-based organization. And so really all the parties who are involved in the sharing need to kind of get together and kind of come to agreement of what they think the rules of the road should be and how they're interpreting these different laws. Consent management is crucial. You need to have an authorization form that meets all of the applicable requirements. Just to say a random one, the California Confidentiality Medical Information Act says forms need to have 14-point font. It's a very random requirement, but if you want it to be CMIA compliant, you need to have 14-point font. And so in the laws will say you need to have certain disclaimers in the forms. So you have to be very careful to figure out what needs to be in the form and how it expresses that information, and also try to convey it in a way that the individual signing it understands it. Because you want consent to be informed, and the goal is not to have someone sign a piece of paper that they don't understand. And along those lines, you need a system for sharing consents, right? If someone signs a piece of paper, but it's just put in a drawer, no one sees it, that's effectively no consent. So there needs to be a strategy for sharing not only the information, but sharing the consent status of the individual. And also relates to that, addressing revocations, because some people will change their mind and say, I no longer want my information to be shared, and there needs to be a means to address that concern. Use workarounds. I mentioned criminal records laws before. Some of that data is publicly available. You don't always need to go to these protected databases that have lots of restrictions about who can access them. Sometimes the information is already out there. And sort of a workaround we're not even mentioning here is, look, this should all be done with with the individual in mind, and hopefully while having conversations with that individual. There's no law that prevents a person from asking that person, where did you live? Tell me about your health history. Tell me, what's your background? That sometimes information can most easily be found out just by asking the person. Consider clients' rights and privacy that go beyond the minimum legal requirements. And so what do we mean here? It's important to follow the law, but sometimes maybe you don't think the privacy laws actually go far enough. Patient access to general information, for example. HIPAA requires that, but do all of the applicable privacy laws require it? Sometimes not. So consider whether you want to have a means of allowing individuals to access their data in all circumstances, even when the law doesn't say that you have to provide such access. That's just one example of how to go beyond law to promote patient rights. Think about how this will work over the long term. Ideally, these are partnerships that are being created not just for 1 year, but for many years. Laws may change. Cultures about what can be done and what can't be done might change. So you need sort of a long-term system of communication between the parties, some sort of governance structure that allows for discussions about these topics and modifications when it's appropriate. And finally, have discussions with regulators when guidance is needed. I think people are often reluctant to approach state regulators and federal regulators on privacy laws, but some clear guidance can be helpful. I think right now the Office of Civil Rights, obviously they're like everyone else is sort of tied up with dealing with the COVID-19 crisis, but they're also sort of prioritizing information sharing for purposes of care management. So there may be agencies who are willing to listen to some concerns. So that's sort of the core of the presentation, and we have just an appendix here, which I don't need to get into, with some citations supporting information, and obviously our report has more detail. But thank you all, and I think we have some time for questions and answers, and I'll turn it back over to Laura.
Thank you so much, Alex and Cindy. There's clearly a lot of interest in this topic, and there's been an active conversation going on in the chat box. I'm going to cluster some of the questions rather than just take them in order, because there are a lot of questions that are very similar to one another. Some of them are related to specific cases, and some of them are broader. So I'll just throw some out there, but audience, please continue to throw questions into the chat box, and I'll do my best to send them over to Alex and Cindy. So I want to start just with this cluster of questions that are about the consent forms. Maybe getting a little bit more into the nitty-gritty around consents for a few minutes. So people are asking questions about examples of patient-friendly or patient-friendly consents or proactive consents. Like, do you need to have the consent done at the time that the data sharing is being done specifically, or could you have one that's just sitting on file? Is there a move towards more universal consents where some of the state laws, especially now in this sort of virtual world we're living in, where there'll be kind of some kind of virtual consent? Are states trying to make their consents more similar across state settings? If you could just dive in a little bit more, that would be great.
Sure. So I can start with that. So I don't see a movement so far to sort of unify state laws on what needs to be consent, and I think that's it's certainly a good idea to do that. There's a real tension, right? Because you want these forms to be understandable and in plain English, and or when they're translated, obviously a different language, but something that someone who sees it kind of understands what they're agreeing to. But then you have many different laws that apply many different rules about what the form needs to say, and it ends up with a kind of a lengthy form that people tend not to read as clearly. So so I think there is a lot of, I think that's a good sort of area of advocacy, is sort of looking at this and saying, look, we're now in a world where that health information and social service information and criminal justice information may end up coming together. Maybe we should think about unifying our consent policies. So I think that's a good point. Another kind of thing to think about is, are we going to move more to verbal consents instead of written consents, right? So most of the assumption is that this is a piece of paper that people sign. But I think this is one thing that kind of, the COVID-19 crisis is bringing on. People now often are not going to be in the same room as their provider. They may be receiving services from telehealth. There may be, goals to keep people, social distancing. Is it really worthwhile to have someone sign a piece of paper, or can a conversation that that covers the main elements of a consent form, is that enough, or is there a way to provide information on people's phones about what they're consenting to? I think these are things being explored. I don't see any answers on these issues yet. So I think that's more of a future direction where things may go.
Great, that's super helpful. There are a number of other questions about consent. So I'm thinking that there's there's like some people have flagged that SAMHSA has a open source electronic consent. People are asking questions about audit trails for consent. I mean, I think that those are all related to these topics that you're raising. Like, could there be a common one? Could it be stored somewhere in the cloud? Like, one day will it be visual? Where do you see consents going in the future? What's your vision?
I mean, I could talk about personally. For me, what makes sense is, and yes, is that basically there would be some consent that people can always access, electronically, and that obviously addresses issues about who has electronic access, but putting that equity question aside for a moment, and where exactly at all times what you've consented to, and you can access it, and you can change it at any time. You could say, I don't want my health information to be shared. Check a box, and then if you change your mind, you can change it the next day, and that can be shared with all your providers, everyone involved in your care, social service, whatnot, immediately. I think that to me is sort of the ideal. We're nowhere near there. There's both technologically and legally, but that to me sort of promotes patient rights, but at the same time allows information to be shared to the extent that people allow it.
So a few people else have asked questions about how the state of emergency, either in specific states or nationally around COVID-19, may change the need for consent in some of the use cases that you just highlighted. Do you see any exceptions currently, or is anything has anything been flagged for you lately?
So in California, the governor issued an executive order where he waived most of the state's health privacy laws, and maybe even all of them, related to the provision of telehealth. So that could impact some of these use cases, but that's that's temporary. It's tied to the public health emergency. It's not a permanent change. The Office of Civil Rights at the federal level has provide some HIPAA flexibility generally regards to telehealth and a few other areas. Again, that's more temporary. I don't see anything that permanently changes this dynamic and over the long term. To me, it's more of a question of, are people going to now reassess laws and regulations in light of what's going on, or are they going to say, are these particular privacy protections are useful, we need to keep them, while these are just barriers that are not that helpful to patients, and maybe we'll reassess that I think is where it would probably be more impactful rather than what has occurred so far.
Super helpful. I do want to encourage people who have specific questions about consents to also look in the chat box, because people have made some great suggestions about where to find more information about actual specific consents that may work across different contexts. So please learn from one another as well. Cindy, I have a question for you, because a number of the comments are also, you started to respond to one, but I think there's several other questions about the privacy implications of the new technology platforms that are trying to bridge medical services and health service delivery settings. And I know that you have looked into this some. It's not part of this report, but I know that Manatt has done some work in this area. Do you want to talk just for a few moments about the privacy implications of those new tech platforms?
Yeah, though I was pretending to be Alex when I entered into the chat box on that discussion. So let me say briefly what I think our finding is, but invite Alex to chime in. In general, and certainly these use platforms, IT platforms, are becoming more common to help facilitate the exchange of information among different entities. And for the most part, our finding is that the use of the platform itself does not alter the results in terms of whether information can or cannot be exchanged, or whether it can be exchanged subject to different kind of consent requirements, as Alex has laid out. So it doesn't superimpose its own restrictions in terms of the law. Now, some people in the chat boxes have noted that some of the platforms themselves may have put forward certain requirements, but the law doesn't address it specifically. So, Alex, I don't know if you want to add to that or
Yeah. I mean, I think what Cindy said is absolutely right. I mean, I think there's maybe a couple of other things. One is that to the extent a platform comes with a consent management service, that can be helpful. It doesn't change the underlying law, but it just can make things easier. There is a bit of a Part 2 wrinkle in that there is a bit more flexibility for disclosures with HIEs regarding those treating provider relationships. There was a statutory change to law underlying 42 CFR Part 2 in the CARES Act. So my instinct is that those Part 2 consent rules are going to change anyway, so that may not really matter next year. But for now, it does exist. Yeah.
Great. So there were some questions that are specific to some of the cases, and I'm going to highlight a couple of them. We won't be able to go through all of them, but there were several questions about the housing case, which I think everybody is so interested in and struggling with right now. And I think that most of them have to do with this question of when a clinician is sending patients info to a housing provider, does there have to be some kind of business associates agreement, or where does the authorization come from that allows a clinician to send patient info? And what are the cases where you don't need to consent or get some kind of consent? Are they assuming that the housing vendor is some kind of healthcare provider, or what's the rationale for that?
Yeah. So it's a little complicated. It's sort of a HIPAA question, but I'd say the bottom line is that HIPAA actually doesn't say that all disclosures for treatment purposes need to be made to covered entities. An organization can use or disclose its own information for treatment purposes, and there's regardless of whether the recipient is a HIPAA covered entity, and there's a bit of guidance from the Office of Civil Rights that talks about basically this use case. I think it's a referral to a provider of services, housing provider to mental health mental health housing provider. And so basically the question is whether the practitioner who maybe has some information about the individual's mental health diagnoses can mention that in a referral to the housing provider. And the guidance basically says yes, they can. And we cite that guidance in the report. So if you want more details on it, I recommend you take a look. But it's just an example of there being more flexibility than people sometimes realize.
That's great, Alex. Thank you so much. So I'm going to throw one more question, Cindy, over to you. And this is a little bit, it's related to some of the questions that are coming up in the chat box, but I want to capitalize, I want to leverage your breadth of kind of policy level expertise. So knowing what you know now about the big barriers that states face, I just want to understanding what CMS expects or what their rules are. I want you to imagine that you're back at CMS, and I'm just wondering if you could do something to mitigate the state-by-state idiosyncrasies and data sharing regulations. What would you suggest? I'm thinking particularly about that food stamp case, where there is some lack of clarity about whether or not that food, the food information or the eligibility information, enrollment and eligibility information actually counts as a treatment related. What kind of changes could CMS or directives could CMS make that would help us as we all interpret these different laws?
Yeah, good question. So I think there's a couple of different things that and a couple of different levels of activity that CMS could engage in that could really be helpful. One is your food stamp example. So where there are ambiguous regulations or statutes, or in the case of food stamps, a formal finding that effectuating the connection to SNAP is directly related to Medicaid administration. Those ambiguities or the need for a particular finding obviously can be done by CMS and could be something that folks want to push for. In addition, I would say generally doing plain language guidance to the field on all of the areas which implicate Medicaid and the Children's Health Insurance Program and Medicare, so the CMS jurisdiction on that. And then probably even more ambitious but more useful would be a collaboration across agencies. Right, so you get the Department of Health, and the Department of Education, and you get the USDA running SNAP, and some of the key other departments and agencies that have jurisdiction over some of these privacy rules to come together and to provide, whether it's a guidance, whether it's through use cases, a general guidance for use cases, to be able to provide some authoritative interpretations that pull it together. So I think really the cross-government effort would be enormously valuable. And then to keep the door open, because no matter how many use cases you go through and how much guidance, nuances will come up. So what is a good route for people to get answers to their questions and authoritative answers?
Yeah, it's super useful to hear you talk about that, and I'm imagining that those are some of the next steps that you at Manatt will be working on. I am recognizing that it's 9:59. It's amazing how quickly an hour goes by. I want to share with all of the audience members who've been able to make it to the end that we are planning to share the public chat that includes both the slides and this recording in about a week. It'll be on the SIREN website. The report is there already, and you're welcome to download it. Cindy and Alex's information is obviously on the slides right now, and certainly will be part of the final slides posted. And I just want to encourage everybody to continue this conversation. There's a lot more that needs to be done. There are lots of people who are working in this area and trying to clarify the law in individual states and nationally. So thank you to Cindy and Alex for this great work, to RWJ for supporting it, and to all of you for joining us today. Best of luck. Please stay safe and sane as best you are able. And thanks again for joining us.